Good morning and welcome to Part 1 in the Medicare 101 three-part webinar series, Medicare Fundamentals, hosted by the Florida Hospital Association. Participant lines are in listen-only mode. However, you may submit questions by using the Q&A box on the left of your screen. You may also type comments in the conversation box. There will be several opportunities for questions, and instructions for asking a question by phone will be given at those times. Thank you all for your attention. At this time, I will turn it over to Diane Bennett with the Florida Hospital Association.
Thank you, Amy. Good morning, everyone. I am Diane Bennett, the Director of Education, and I'd like to welcome you to our call today. We are delighted to have you participate, and today's session is on Medicare fundamentals. I'm pleased to introduce our speaker, whom many of you may know. Kathy Reep is the Senior Manager of Business Development and Compliance Advisory with PYA. She has more than 3 decades of leadership experience in the healthcare industry. Her hospital setting experience is in compliance, financial advisory, reimbursement, and managed care. Kathy has helped with Medicare, Medicaid, workers' compensation, reimbursement, and many other complex programs and issues. She is a thought leader and provider educator, helping hospitals navigate regulations and the impact of change. Prior to joining PYA, Kathy served as Vice President of Financial Services with us here at the FHA, and she also held longtime hospital positions working in patient business, internal audit, systems management, and other areas. With that, I would like to welcome Kathy Reep.
Thanks, Diane, and good morning, everyone. Glad you were able to join us for this session and hopefully for the entire series on Medicare 101. I know that you all were able to see the materials, and it's not advancing. The materials related to the, let's see if we can do this. There we go. The materials were, as you registered, related to the program. But I also wanted to mention the next 2 sessions in terms of what we are going to cover. Whereas today we're talking about the fundamentals of Medicare with a focus on inpatient and outpatient hospital payments. We will address very briefly skilled nursing, home health, inpatient rehab, and patient psych, those programs. Our next session is going to be focused on paying for value, paying for the quality performance. And finally, something that will be a little bit different, I think, for those of you in Florida, is my colleague within PYA, Bob Paskowski, is going to really be focused on Medicare Advantage. Medicare Advantage is a major payer in Florida, the various plans. And I think hearing Bob's presentation on some of the fundamentals of MA will be a little bit different for everybody and something that I hope you enjoy. So let's go ahead and get started with the program. And we're going to kind of start with why are we talking about Medicare in terms of, we know it's a big payer, but why do we focus so much on this? First of all, let's look at the overall spending within our country for healthcare. In 2018, an average of over $11,000 per person was expended on healthcare, a total of about $3.6 trillion in 18. We know that this is going to be higher in 2020. It does take a while sometimes for these numbers to catch up, but we do know that the expenditures have been significantly higher this year than they have been in the past. And it might not be something that we would say is a increased expenditure per person as much as through the various CARES Act funding programs, increased dollars going into the system. Well, those will all have to be calculated when we look at our national health expenditures for 2020. In 2018, we were looking at an annual growth rate of about 4.6%, stayed the same for 2019. Again, we're going to see a huge jump in 2020 because of the increased funding. The healthcare expenditures represents almost 20% of our GDP, and it was targeted to grow to about 19.7% compared to 17.7 in 2028. Again, I think we're going to see, when we see the numbers for 2020, we're going to see huge growth this year, not even waiting for those out years. When we focus on Medicare, it's important to look at the fact that Medicare is the largest single person purchaser of personal health care in 2018. The blue bucket on the chart is your private health insurance, and although that shows 35% of the total, that's made up of a number of different payers and plans. Medicare representing 23% of the overall healthcare expenditures makes them the largest single purchaser. A little bit of background on the Medicare program, and I like to include this just to make sure that people understand all the various components that we are addressing when we talk about the Medicare program. The program was originally established in 1965 under Title 18 of the Social Security Act, and it was entitled Health Insurance for the Aged. Now that I am there and Medicare eligible, I am definitely glad that they changed the name because health insurance for the aged just sounds very depressing. But that is how we began, with health insurance for the aged. When it was first established, we were looking at two components to the Medicare program, Medicare Part A and Part B. As you age into Medicare, you are automatically enrolled in Medicare Part A. Medicare Part A covers your inpatient hospital services, skilled nursing, that home care, that portion of home care that is following an hospitalization or an inpatient encounter. Home care services that did not follow immediately upon a encounter within an inpatient setting, that would be paid under Medicare Part B. Medicare Part B is voluntary. You do not have to sign up for Medicare Part B, but recognize that pays for physician services, for hospital outpatient services, your lab services, obviously that home health that is not covered under Part A. The program began with just Part A, Part B, and now we have seen significant expansion, which we will look at momentarily. Within the program, the first major expansion, and one that did have a significant impact on overall costs within the Medicare program, was fairly early. The program was established in 1965. In 1972, it was expanded to cover individuals with disabilities and those with end-stage renal disease. Both of those populations would be younger than the normal age for Medicare entitlement. And we're also dealing with people who will be in Medicare for a longer period of time. And we are also dealing with people who, because of the clinical condition that caused them to be eligible for Medicare, they are going to be users of healthcare, either to treat the disability or to treat them for their end-stage renal disease through dialysis, through a transplant, whatever it might be. But that increased the overall cost to the Medicare program significantly by adding those two populations. There was, and I include this, and I guess I do this for two reasons. In 1988, we had the Medicare Catastrophic Coverage Act. One of the reasons I like to include the Medicare Catastrophic Coverage Act is because few people remember it, but it did a couple of really interesting things. The other reason is because this was one of the first pieces of legislation that I really was in a position to read and talk about what it did for providers and patients. And then, as you can see from the slide, it was enacted and it was repealed. I thought that this would be an easy step going forward. If you don't like it, get rid of it. But that hasn't proved to be the case going forward. But the other reason for Medicare Catastrophic Coverage Act and to include it and to mention it is because back in 1988, the Medicare Catastrophic Coverage Act included a prescription drug benefit for seniors. We are used to the Medicare Modernization Act in 2003 that gave us a prescription drug program, but recognized that there was an original program back in 1988. The seniors did not like it. They didn't like the way it worked, and therefore they worked within a single year to have it repealed. The Balanced Budget Act of 1997, affectionately known as BUBBA, when we blamed the BBA for everything. First of all, it expanded managed care. We had very little Medicare managed care in the early years. It really came in the early 90s, but it expanded the various options for seniors in 1997, so we saw a boom in the managed care programs and options for seniors. And the other thing that it did is, prior to the Balanced Budget Act, we had a reimbursement system for inpatient hospitals that was tied to a prospective payment system. But with the Balanced Budget Act, we went to a prospective payment system for all of the provider types. It required adoption of prospective payment for skilled nursing, for rehab, for psych, for all of the various programs that we deal with. So moved us away from cost-based reimbursement significantly with the Balanced Budget Act. I mentioned the legislation in 2003 with the Medicare Modernization Act giving us the prescription drug benefit. And then in 2010, it's hard to believe it was only 10 years ago, but we had major healthcare reform through the Affordable Care Act, not only with expansion of Medicaid and coverage for the uninsured, but also with a large number of provisions that you are now dealing with that were included in the ACA, that sometimes it gets a reputation. The positive reputation is the expanded coverage. The negative reputation is the increased regulatory burden on you as a provider. As an example, right now you are all dealing with issues related to price transparency, posting rates and negotiated payment rates with the plans. All of that ties back to requirements under the Affordable Care Act. So let's talk a little bit about how Medicare is financed. Medicare Part A, which is that hospital insurance that covers, you are automatically enrolled, and it does cover your hospitalization, your skilled nursing, your inpatient stays. That is financed through a 1.45% payroll tax on you as the employee and on your employer, a total of 2.9%. We're going to talk about that a little bit more in a minute, but a 1.45% payroll tax. The Medicare Part B is your supplemental. There is a premium that individuals have to pay to have Medicare Part B. There is a requirement, and previously we had a fixed premium amount, and what we were seeing was that general revenues were paying more and more for Part B services, or paying a larger portion of the total bill because of that fixed amount for the patient monthly premium for Part B. Where we are now, and this was a result of legislation in the 90s, but they did modify the requirement for the beneficiary premium, and it requires CMS to do an analysis of how much is expected to be expended under the Medicare Part B program in a year, and whatever that amount is, that expectation, 25% of that should be paid through beneficiary premiums. There is actually even a higher premium for those who are have higher income levels. But the idea is that the beneficiary is going to have a premium for Part B, and overall premiums are established to cover 25% of expected Part B spending. As we have increased outpatient services, I think you're all aware that we're seeing this trend. Things are obviously moving from the inpatient setting to the outpatient setting. As we have things leave Part A and go under Part B, obviously spending under Part B goes up, and therefore the amount of money that beneficiaries have to pay in their monthly premium to Part B, that also is going up significantly. Medicare Part C, this is your Medicare Advantage program. It is not separately financed. Individuals who are in Part C are also required to be in Part B, or to have Part B, and then obviously they were aged in to Part A. The main difference is that the payments through the Part A program, the Part B program, are going to the Medicare Advantage plans, and then the plans are paying the providers as opposed to being paid directly from the Medicare program from CMS. And then, of course, we have Medicare Part D. Medicare Part D is your prescription drug benefit, and this came along through the Medicare Modernization Act. Beneficiaries have a premium that they are going to pay every month for Part D, but that premium is going to vary by geographic area. That is tied to, significantly to the overall expenditure for drugs and the nature of drugs within a particular market, and that is going to establish the beneficiary premium. And then the balance of the expenditures for Medicare Part D are also made up from general revenues. One thing that I wanted to mention about Medicare Part B and D, both of them have that beneficiary premium. And if you age into Medicare and you are a working senior, you are working and you have insurance, Medicare Part A becomes your secondary insurance to that insurance that's provided by your employer. But many individuals do not purchase Part B and Part D because, again, their employer-sponsored insurance is their primary. There's no problem with continuing that, but as soon as you no longer have creditable coverage for outpatient services, physician services, prescription drugs, it's important that you do move forward and sign up for Part B and Part D, because failure to do so when you no longer have creditable coverage will increase your premium for that year and all subsequent years. So you will have a higher premium if you do not first sign up for Part B and Part D when you first no longer have creditable coverage. Excuse me, you can see the change in the number of Medicare beneficiaries from 1 year to the next, or from one 10-year period to the next. You can see that when the program first began, we really did not have that coverage that was linked to the disabled and those with ESRD. It was predominantly tied to the elderly population. But you can see that as we move forward, we are looking at the impact of the baby boomers, as we see this huge jump in those who qualify for Medicare based upon age. But we are also seeing a significant bump in those who qualify for Medicare based upon disability or end-stage renal disease. Those volumes are also projected to continue to increase. A little bit about the Medicare Trust Fund. The Medicare Trust Fund is when you as an employee and then as an employer are paying for the future of Medicare Part A, that 1.45% on each of you that goes into the trust fund. There is a trust fund, the trustees of the fund, who meet on a regular basis and assess the future of the Medicare program, the Medicare Trust Fund. Every year in the spring, they issue a statement, a report, where they have done an analysis on the future of the trust fund. And this year is probably the most important year for the future of the trust fund since I've been doing this. When the report came out last year, the trust fund was expected to be viable until 2026. When the report came out in early April this year, they again said 2026, the same year as they had said last year. And then they also said that at that point, 2026, the fund's reserves would become depleted and continued program income would be sufficient to pay 90% of total scheduled benefits. Now, this is paying, remember, for inpatient services, whether it be in the hospital or within a skilled nursing setting or home health. But they would be projecting that as of 2026, they would only be able to pay you 90% of what they owe you. We complained enough about sequestration that reduced our payments by 2%. Let's talk about reducing by 90%. So what has happened since the trust fund report came out in April? There was a report in, if you think about other things that were happening in April, we are looking at the sudden impact of COVID, the sudden reduction in those who were working. A number of people were either furloughed or actually lost their jobs completely. Therefore, those dollars, that 1.45% on the part of the employee and the employer, were no longer going into the trust fund. And we also had a significant spike in expenditures. There was an article in Modern Healthcare in April of 2020 that said the 2020 assessment has an elephant in the room. The global pandemic will, no question, have a negative effect on the reserve funds of both Medicare and Social Security. In a high-cost environment, that reserve would run out by 2023. Within a matter of a month, the impact of COVID was assessed on the Medicare Trust Fund, taking it from 2026 to 2023. And then, of course, they come up with lines such as, it's possible that the experience could be even worse than that. And then it's too early to say exactly what the impacts are, but they are generally going to be worse than presented under the intermediate assumptions in this report. And then finally, when the trustees incorporate the effects of COVID on the payroll tax revenue and other factors in next year's report, the situation will go from bad to worse. This was what they were saying in April. And I think in April, we were all trying to wonder, are we going back to work in May or June? We didn't think it would be people working from home and so many people having lost their jobs in October. And actually on a news report this morning, I heard someone say, we're probably looking at 3 to 6 more months of this and it could get worse. Well, this is the impact on the trust fund and the ability to pay bills to healthcare providers. What does it mean if the trust fund is exhausted? It's essentially Medicare could pay health plans and providers of Part A services only to the extent allowed by ongoing tax revenues. Beneficiary access to healthcare services would rapidly be curtailed. For the hospital insurance trust fund to remain solvent through the 75-year projection period, because the trustees are expected to project for 75 years, the standard 2.9% payroll tax would have to be immediately increased to 3.81. So that's an increase on you as an employee and on your employer, or expenditures reduced by 19%. Remember that we said earlier a 10% reduction in expenditures. Well, now they are saying no, it would be closer to 19% reduction in expenditures. So now you would be looking at your normal reimbursement from Medicare less, almost 20%. The other thing to think about as we look at this program and the impact of COVID on the Medicare Trust Fund is we have people who are even looking at deferring paying their payroll tax. what does that do as we start looking at this in the future if they don't ultimately make up that payment on the payroll tax? Hopefully not too many employers are making a decision to do that. I think next spring's report from the trustees will be frightening. Congress has to do something. We all recognize this. I would share with you that in the one of the Republican bills that was introduced as, I guess I would like to say, CARES Act 4 point whatever, there was actually legislation included in one of the bills in the Senate to address the Medicare, Social Security, and highway trust funds by creating a bipartisan trust fund rescue committee that would have to produce legislation within a set time period. And then that legislation that was established by that committee would have to be reviewed by both the House and the Senate. And they were doing that in response to a 2026 expiration date or exhaustion date of the trust fund. And we recognize that with everything that has happened this year, we're probably looking at a sooner date. Unfortunately, we have no rescue committee established. When we start looking at Medicare and the payment for services, where is the money going? This slide kind of compares 2019 to 2010 in terms of the expenditures. You can see, first of all, a huge jump in the total spending from $517 billion to $787 billion. Medicare Advantage, that is the darker blue. You can see the increase in Medicare Advantage spending on the slide. You can also see the decrease in inpatient spending. Inpatient services kind of dropping a little bit, as are physician services. But you can get the idea in terms of where is the overall spending going and where it is within the program. We talk a lot about prescription drug spending, and you can see actually that we have a decrease in prescription drugs, outpatient prescription drugs. Actually, I'm looking at actually it's home health I was looking at. Excuse me, a decrease in expenditures for home health. When we look at Florida, just to give you an idea as to the Medicare enrollment within the state, about 4.5 million individuals. That represents about 21% of our state population. Of those individuals who are eligible for Medicare in Florida, about 800,000 of them are what we consider dual eligibles. They are eligible for both Medicare and Medicaid. Medicaid would be picking up their out-of-pocket liability. Total benefit payments, about $47 billion, about $12,000 per enrollee. Of that 4.5 million Medicare beneficiaries, 1.9 million of them are in Medicare Advantage. That represents about 43% of our total beneficiaries. And as of 2019, there were 33 different Medicare Advantage contracts within the state of Florida. So just something to give you an idea of. Did a presentation similar to this for Ohio and Georgia recently, where we could see that the number of, okay, my slides are moving, where we could see that the number of enrollees, let's go back here, where the number of plans was actually significantly smaller than it was in Florida. So let's keep going here. Again, a little bit more before we actually get into payments, but let's talk about what a patient pays. Within Medicare Part A, the individual patient is going to have what we used to call 60-30-60 in terms of calculating their days. Patient has 60 basic days, 30 days where they have a coinsurance liability, and 60 days where they move into lifetime reserve days. During that 60-day period, they have out-of-pocket liability. They have a deductible that they have to make. And then under the 30-day coinsurance period, they have already paid their deductible, but now they're going to go into coinsurance and have a portion per day. If a beneficiary opts to use lifetime reserve days, then that individual is going to have a higher coinsurance amount per day. Both the basic days and the coinsurance days, best word I can use is regenerate. They restart if the patient has been out of an inpatient setting for 60 consecutive days. So let's say a patient has gone into the hospital, they are in for 20 days, they come back within a month, and they're in for another 20 days, back and forth. Once they have been out for 60 days, they would have a new deductible because their basic day period begins. If they have moved into a coinsurance period, that is going to, they would no longer have to pay coinsurance for their next encounter if they have been out of an inpatient setting for 60 days. So that is something that you have unlimited benefit periods under the basic and the coinsurance days. But under your 60 lifetime reserve days, they are just what the name implies. You only have 60 of them. If you use a lifetime reserve day, you don't get it back. You do have patients, particularly some of your younger Medicare beneficiaries who didn't age into Medicare but qualify because of disability or end-stage renal disease, who are into their lifetime reserve days. And you have to, just as a reminder, particularly those of you who might be on the revenue cycle, the front end, the patient financial services end within your hospital, if a patient is going into or approaching using their lifetime reserve days, you do have to ask the patient if they want to use their lifetime reserve days. And you have to get, if a patient does not want to use lifetime reserve days, they do have to sign that they do not want to use them. But then you're going to have to be making other arrangements for how the patient's bill is going to be paid. But it is patient discretion as to whether or not they want to use their lifetime reserve days. Under the inpatient deductible, you are looking for 2020 at about a little over $1,400 for the individual. And this would be every 60 days that they have been out of the hospital. Once they go into their copay days, it's $352 per day. Skilled nursing, you don't have a copay for the first 20 days, but between days 21 and 100, you have $76 per day. If after day 100 in the skilled nursing setting, then the Medicare, if it is a consecutive stay, or there has not been that 60-day break, then the patient is responsible for all costs within that SNF setting. Patients have an annual deductible under Part B of $198 per year, and then they have a coinsurance liability for the services that are provided that is usually 20% of Medicare allowable. That is not necessarily the case for hospital outpatient services, but within a physician setting, it would be 20% of the allowable. When we look at those beneficiaries and who has and who doesn't have coverage to pick up their out-of-pocket liability, this chart kind of shows you that only about 19% of the Medicare beneficiaries do not have coverage to pick up their out-of-pocket liability. There tends to be something there. Large number of them are through employer-sponsored insurance, followed very closely by Medigap and Medicaid, but only again about 19% of Medicare patients do not have supplemental insurance to pick up their out-of-pocket liability. Now we're going to start focusing on how Medicare pays, and let's dig into this. So there are three basic methodologies for Medicare reimbursement: cost-based, fee schedule, and a prospective payment system. As we go through this, you'll see that the fee schedule is very similar to a prospective payment system, but cost-based reimbursement is just what the name implies. What did it cost you? And I'm going to give you a percentage of your cost, reimburse you for those things that I consider allowable, and I'm going to reimburse at a cost level. So focus on cost-based reimbursement first. That's where we all started. If Medicare represented 70% of your overall patient volume or your patient revenue, then what you were dealing with was 70% of your allowable costs were going to be reimbursed by the Medicare program. Medicare does what's called a retrospective settlement of your costs. They're going to pay you based upon your prior year costs. They're going to trend it forward slightly, but then you're going to settle when you file your cost report for cost-based reimbursement. And we'll talk about specific providers who get cost-based reimbursement momentarily. You usually are subject to a limit in that your costs cannot just be whatever. They are subject to a limitation on the increase in the reimbursement. And for most programs, we do have a base year that we are looking at. That base year is trended forward by changes in the cost of doing business, and that you're not recalculating your costs each year. You're using that base year going forward. It's important to recognize that all of the costs, all of the costs of providing care are not reimbursed by the Medicare program. We have a number of things that they have very clearly said these are not allowable. And I look at the list of unallowable costs, and I think it's kind of interesting. Patient telephones are not considered allowable. I know that in many instances, you're going to have, obviously, phones within a patient room, but those are not considered allowable under the Medicare program. A TV in the patient room is not considered allowable. However, I dare you not to have a TV in a patient room. That's one of the reasons that the auxiliary often sponsors the TV within patient rooms. But I think it's interesting that they still haven't recognized the fact that patient TVs lead to patient satisfaction. Advertising is a service that you all participate in, but it is not considered allowable, nor is lobbying expense considered an allowable expenditure under the Medicare program. And if you are cost-based and you exceed the limitation on how much your expenditures can increase from one year to the next, obviously then those dollars in excess of that limit are not considered reimbursable under Medicare. There are a number of different ways that Medicare does a cost-based allocation. They use a lot of statistics for allocation of costs, things like square footage, time studies, patient days, FTEs, even pounds of laundry. If you have a laundry program, or if you're using an outside service, you're going to allocate the costs of laundry and linen down based upon pounds, down to the various nursing units, down to dietary, down to various other areas. You're going to use square footage for actually looking at the amount of space and the overall campus that is dedicated to patient care versus administrative areas. And you're going to, even as you do a square footage study, you're going to be looking at things such as hallways and who goes down this hallway, what departments share it, so you can allocate that hallway based upon the appropriate departments or areas within the organization. This is something that is done by those within your organizations who are involved in completing and filing the Medicare cost report. A lot of times you'll see that on a fairly frequent basis, but obviously not every year, a square footage study is done, time studies are done, things like this, to make sure that you are getting the most appropriate level of reimbursement within your organization. As I mentioned before, you receive interim payments based upon prior year data, and then we're going to look at your cost report to do a final review and determine your final cost. And you will either owe the Medicare program or they will owe you based upon final information from your cost report. Now, when we look at who is reimbursed based upon cost, the number one provider that we always go to is your critical access hospitals. But recognize also that those of you who have a teaching program, your teaching program is reimbursed for your direct graduate medical education. That is cost-based. Rural health clinics are cost-based, and Soul Community Hospitals, you basically get the higher of the prospective payment system, or base your cost trended forward. Trended forward. So I'm going to focus on critical access hospitals just to give you an idea, make sure that we are all understanding what we're referring to by critical access hospital. Critical access hospital, also called a CAH, C-A-H, is located in a rural area, either defined as such by the state or federally. Must be at least 35 road miles away from a similar hospital. But if you are in an area that either due to mountainous terrain or weather conditions, it makes traveling hazardous, then it could be a 15-mile distance. We don't have that issue in Florida. That's going to be more in the West and like that. That critical access hospital must provide 24-hour emergency service and can have no more than 25 beds and an average length of stay of no more than 96 hours. It doesn't mean that a patient can't be in the hospital longer than 96 hours, but your average length of stay is no more than 96. Now, I will comment that those last two bullets were both waived during or they are waived during the public health emergency to allow critical access hospitals to have more beds and to have a longer length of stay as necessary. But these are the basic rules for qualification as a critical access hospital. Critical access hospitals are reimbursed for inpatient acute care services, swing bed services, outpatient services, and certain ambulance services at 101% of allowable costs. Again, it's not all costs, it's allowable costs. There are no limits on how costs can increase from one period to the next, but they are reimbursed at 101% of allowable costs. When I mention ambulance services, if there is another entity providing ambulance services nearby, then the ambulance services provided by the critical access hospital are going to be reimbursed under the ambulance fee schedule, not under allowable costs. And there are some areas of the country that this has been a real issue, because although a critical access hospital would have an ambulance service available, there are others who compete, government-sponsored programs, that kind of thing, that really causes issues and threatens the reimbursement for those smaller providers. Many of the critical access hospitals across the country also offer other types of services, and this would be beyond those 25 beds. They offer rehab, psych, home health, and skilled nursing services. All of those are going to be paid under the appropriate payment mechanism. Rehab, all of these actually being paid under a prospective payment system that we'll talk about as we go forward in the fundamentals of the rehab and psych and home health and skilled nursing payment programs, but they would be paid under those programs. Now, the thing that is important to look at is that other than psych, most of these programs have an add-on for services provided in a rural area. Therefore, if you are providing services, actually I think it's other than rehab, if you are providing the services in a rural area, they might actually be paid more than those who are providing the services in an urban area. But we'll walk through that momentarily. Fee schedule reimbursement is the next area I wanted to look at briefly, and then we're going to get into prospective payment and the detail that we need to. But fee schedule payments are, in my mind, basically just another form of a prospective payment because they are predetermined rates that are for individual services. You might have within a physician's office an evaluation and management service, and you're going to have a reimbursement that is on a fee schedule, but it is determined in advance for a particular level of evaluation and management service. Many fee schedules are adjusted for provider characteristics and location, whether it's provided again in a physician's office, in a hospital outpatient clinic, things like that, that will have an impact on the reimbursement level. Fee schedules are used to reimburse physicians predominantly, but then hospital outpatient therapy services and hospitals diagnostic and screening mammography services are actually paid under the physician fee schedule. Many lab services, outpatient lab services, are also paid under a fee schedule, as are ambulance services. I'm going to focus on the physician fee schedule methodology, but recognize again that your hospital outpatient and outpatient therapy, as well as diagnostic and screening mammography, are paid under that fee schedule, the same thing that the physicians get. So let's look at physician reimbursement. Again, I stress that it is similar to a prospective payment system. I am going to start with a base rate. It's a federal rate. They call it the conversion factor. Everybody starts out at the same point under the reimbursement under the physician fee schedule. There is a different conversion factor for anesthesiologists, but for all other physicians, we are looking at a base rate of $36 and about 9 cents. For this year. Now for 2021, we have a proposed rule for the physician fee schedule, and we are looking at almost an 11% or proposed 11% reduction in the physician fee schedule, taking us down somewhere around, I believe, about $33. So we'll see what happens with the final rule on that, but that was a huge decrease projected for physician reimbursement. Under the physician fee schedule methodology, we start with that conversion factor, and then we have what we call relative value units. And there are 3 different relative value units that are calculated for the physician fee schedule: work, practice expense, and malpractice expense. Work is essentially looking at the service intensity. How resource intensive are the services that are being provided in that particular encounter? Practice expense looks at whether or not the service was provided within the physician's office or in another setting. And so that's something that we will look at when we do a calculation momentarily within the facility versus within the physician's office. Malpractice expense is exactly what it says, the cost of maintaining your business and maintaining insurance. Within the physician payment methodology, for each of these RVUs, we have what's called the Geographic Practice Cost Indice, or GPCI. Many of you are familiar with the wage index. We will talk about wage index, but think about the GPCI as similar to a wage index for the variation within the costs of doing business from one geographic area to another. What is the difference in, let's say, malpractice expense in Florida versus in Kansas? Or actually, let's even narrow it down and say Miami versus Pensacola. So we do have the Geographic Cost Practice Index, the Geographic Practice Cost Index, GPCI, and there is a separate GPCI for each of the RVUs. So let's look at the formula. And I think my joke is that we call the physician reimbursement a fee schedule because all of this information, the math is already done and calculated for the physician in a table. When the final rule is published, doing this calculation, they don't have to do all the math that you do in a hospital for your outpatient or inpatient reimbursement. But here we go. You're going to take the work RVU times the gypsy for work, add to that the RVU for practice expense times the gypsy for practice expense, add to that the RVU for malpractice times the gypsy for malpractice, take that sum and multiply it times that $36 conversion factor. So a very complicated calculation if it actually hadn't been provided, already done, and therefore we have a fee schedule rather than a prospective payment system. But let's look at a particular service in a physician paid under Medicare Part B. And I'm using a very simple service. This is going to be a new patient in office or outpatient visit. And you can see that I have two columns there. The non-facility setting means that the physician did this service in his office, as opposed to a facility setting, which means he provided this service perhaps in a clinic that is owned by the hospital. In both cases, I am starting with a conversion factor, spelled wrong, I apologize for that, a conversion factor of 3609. And you can see that I take my work RVU times my gypsy. You can see that I do the same for practice expense and malpractice. But under practice expense, you see that the practice expense RVU in the physician's office is significantly higher than it is in the facility setting. That is because when this service is provided in the physician's office, he is incurring the cost of he is incurring the cost of the staff, the physical space, etc. Whereas in the hospital setting, it is incurred by the hospital. So you go through, you do your math, you get a total weight within the physician office of 1.27 and within the facility of a 0.76. You multiply times your conversion factor. Physician performing this service within his office gets almost $46 and closer to $27 when it is provided in the facility setting. But recognize that when this service is provided in the facility setting, the hospital is also being paid for the service that is being provided. They are getting reimbursed under the outpatient prospective payment system. And I can guarantee you that if you take the $27 going to the facility, add to that, or the $27 going to the physician, and you add to that the dollars going to the hospital for the space and the services provided, it will be higher than the $46 that the physician gets for providing the service in his office. This has become an issue of major concern for the Medicare program as more and more services are moving from a physician office or a physician-owned office into a facility-owned setting. That's why we're seeing major adjustments to our reimbursement for services provided in off-campus provider-based departments or even in certain clinic settings. So let's go forward. That was our first two payment methodologies. Now we're going to be focusing on prospective payment because this is the bulk of the reimbursement for your hospitals. So when I look at who is paid under a prospective payment system, you can see that just about everyone is. But you can also see at the very beginning, you think I did a typo, but I didn't. Under the hospital prospective payment system, we actually have two different calculations. One is for hospital inpatient operating, and one is for inpatient capital. There are two different calculations that are used, and actually some different terms and terminology that is included. But you can see that just about every type of setting, or every setting, is now under a prospective payment system. Again, recognize that prior to the Balanced Budget Act, we really were only looking at inpatient hospital services being paid under a prospective payment system. When we look at a prospective payment system, we have a certain number of basic elements. They are common to all settings, excuse me, but I'm going to keep drinking water. These components are common to all of the payment systems. So let's start with the base rate. Similar to what we talked about with the conversion factor for the physicians, we're all going to start with a single national payment rate. Facility adjustments. Based upon all of the different prospective payment systems, they bring in various adjusters based upon who is providing the services. Tell me about the facility itself. There are differences in area wages. There are prospective payment systems that modify the payment rate based upon whether the services were provided in an urban or a rural area. If you are a teaching facility, many of the prospective payment systems reimburse you for medical education. This is indirect medical education. Your direct medical education is reimbursed under cost. We mentioned that earlier. Direct is actually the cost of operating the education program. Disproportionate share of low-income patients. If you are a provider that serves a large volume of low-income patients, there is, under many of the prospective payment systems, again, an adjustment to your payment rate. Then we also have adjusters tied to the individual patient. The intensity of the services provided to the patient are addressed. And then we also have various components in the prospective payment systems that looks for extremely high cost cases, or those instances where a provider did not provide the full level of care to a patient. And we have adjusters to reduce payment based upon partial treatment. It is very important that you pay attention to the rules that come out to modify the rates. I cannot stress it enough. There is a proposed rule that comes out every year for each of the payment systems that says, these are the things that we are thinking about doing. These are the changes that we are proposing from one year to the next. I mentioned that under the physician fee schedule, they are proposing almost an 11% reduction to their payment rate. So we have a proposed rule. There is a 60-day comment period, and usually there is a 60-day implementation period once the final rule comes out. The final rule is going to respond to the comments that were submitted. Sometimes CMS follows the comments, and sometimes they do what they intended to do all along. But it is worth commenting. I'll talk about that in just another minute. But I do want to mention the fact that this year, for a number of the rules, because of the public health emergency, hospitals did not get a 60-day implementation period from the final rule to its effective date. It has been modified to a 30-day period. So just wanted to make sure that usually you have a 60-day implementation period. This year, we are only looking at 30. In terms of commenting on proposed rules, the reason I think this is so very important, and I urge you to do it from the perspective of both those things you don't like and those things that you do. Because if something benefits you, there is a strong possibility it might hurt someone else, and they're going to comment on it. So if you like it, you might want to comment and say that this is a positive change and the positive impact on your organization. Because again, if it has a negative impact on someone else, I pretty much guarantee you they will be commenting. I know that from my time within the Florida Hospital Association, many providers would think that the FHA was submitting a comment letter and we can just let it ride with that. Well, from an association perspective, there are times that our hands are tied. and that there are some things we really can't comment on because there will be members within an association who both win and lose under a proposed rule. And therefore, it's very hard to say, do this one, even though it hurts 20, 30, 40% of our members. So those are some of the issues that you as an individual provider need to comment on. And you need to be willing to write a letter within your organization looking at those changes that are positive to you or even negative to you, recognizing that sometimes your association can't comment on those because of winners and losers. One of the things that is always included within the proposed rules, and obviously then finally addressed within the final rule, would be a market basket update. How are we going to increase or decrease your payment rates from one year to the next? We are going to be looking at what we call the wage index based upon more current hospital salary information. We're going to get into the wage index in detail momentarily. Relative weights, this is going to be how we measure the acuity of an individual case. Those are going to be updated and modified based upon more current data. If there is new technology that makes it easier to perform a particular service, that is going to be modified under the proposed rule and finalized, of course. And then the area that I always have to be most cautious about is quote unquote other changes to improve payment policy. That's where you're going to be getting into some rules that maybe you are very concerned about. Very simple example that I'm going to give right now, payment to 340B providers that under the CMS policy to improve payment policy. The proposal, well, actually the current methodology of average sales price minus 22.5% for the drugs when you were being reimbursed average sales price plus 6. And then the proposal now to further expand that to average sales price minus, I believe it was 28.7. So again, that is their improving payment policy. Another one that they did to improve payment policy was to reduce the payment for off-campus clinic visits, the E&M, even if those clinics were grandfathered. So that is, quote unquote, under the section of improving payment policy. I think those are the ones you have to be most cautious about under as you read these rules. Let me talk about the wage index, and when we get to the inpatient system, we'll actually start applying it a little bit. But the most important component, I think, to a prospective payment system is the wage index. The wage index is going to measure the relative level of hourly wages from one labor market to a national average. So just give you an example here. Here we go. Somebody is touching this. I got two different locations. I have location A with a wage index of 1.0469 and location B with a wage index of 0.86. Now I'm going to multiply a portion of my base rate by the wage index. Won't be multiplying the whole thing, but the portion that is considered attributable to salaries and benefits ranges across the different payment programs between 60 and 78.5%. So I'm going to be multiplying, let's say for hospital outpatient services, 60% of my base rate by a wage index. I want to multiply by 1.0469 because that's going to increase my base rate. If I am multiplying it by 0.8698, I am obviously going to reduce my base rate. So getting your area wage index correct is vital. Under the looking at the acuity of a service, this just gives you an idea of under the inpatient program, We have multiple categories, which we call MSDRG, Medicare Severity DRGs. I've used a quick acronym of just a DRG for the slide. But I have 3 different DRGs that are all tied to simple pneumonia and pleurisy, but they vary in terms of the intensity based upon whether the patient has complications or comorbidities, or even major complications or comorbidities. To give you an idea, under that DRG 193, simple pneumonia and pleurisy with a major complication or comorbidity, a patient who presents with simple pneumonia who also has acute and chronic respiratory failure, that's going to go into 193. Whereas the patient who presents with that same simple pneumonia diagnosis and has chronic respiratory failure, that is going to go into DRG 194. And if they do not have any sort of respiratory failure, then that patient is going to fall into simple pneumonia and pleurisy without a complication or comorbidity, or a major complication and comorbidity. But you can see, based upon the weight of those 3 DRGs, that obviously the more resource-intensive patient has a higher rate. And if I multiply my payment rate times the weight, that higher, greater than 1, is going to increase my overall reimbursement. So let's take a look at the inpatient operating prospective payment system and how it works. Then we're going to take the components that we looked at here and apply them to the rest of the programs very quickly. When we first began under the inpatient operating prospective payment system, and that would have been in federal fiscal year 1984, we began with 3 different payment rates, but we have now moved, as of 2004, to a single payment rate. It's called the standardized amount. For 2020, it is $5,796.63. We all start out at the same place, with the exception of if you have a hospital that is not participating in the quality initiative, the reporting of quality information, they would be seeing a 2% reduction in their standardized amount. We have various components. All I can say is the idea, the concept of a wage index has been really messed up. That's the best word I can use. The one I'm thinking of, I'm not going to use, but it's been really messed up by legislation and various regulation over time. So let's kind of look at the wage index. First of all, you have the ability, you have within your geographic area a wage index that is actually the wage index for your market. However, under the inpatient system, we do allow hospitals to reclassify from one geographic market to another. If a hospital in one market is not like the rest of the hospitals in their area, and they are close in proximity to another geographic market, and they are closer aligned to that market, they have to be geographically contiguous, but they can reclassify from one market to another. We actually, for a number of years, had all of the hospitals in Miami-Dade reclassified to Broward because of their ability to do that. We have what's called a rural floor. The rural floor means that urban hospitals or urban markets within a state cannot have a wage index that is less than the statewide rural floor. For many years, that requirement has impacted the hospitals in the panhandle of Florida because the wage index in that area was lower than the statewide rural, so they were brought up the statewide rural rate for inpatient and certain other programs. We have under the inpatient program 2 different labor shares. We have a labor share for those who have a wage index less than 1, and a different wage index for those who have a wage index greater than 1. This was mandated by Congress. The wage index for those less than 1 is statutorily stated, and those greater than 1, it varies from year to year. If you are a hospital in a rural area that borders an urban area, and individuals have a tendency to commute to that urban area for work, you have the ability to have an adjustment in your wage index because of that commuting pattern. In other words, to keep individuals, clinicians, and others within your hospital and within your market, as opposed to driving elsewhere, you do have that ability to get an adjustment if you border an urban area where there is significant commuting. And then one of the strangest things that they did within the hospital inpatient wage index is what we call an occupational mix adjustment. And I would try to explain it, but it is much easier to show you pictures. The idea of the occupational mix adjustment is to, if you are a hospital with a high case mix, the acuity of your patients is high, you're going to have a higher level of staffing to take care of those patients. There were complaints that if you had high acuity and you also had a high wage index, you were actually getting a bonus reimbursement because you already got paid for the intensity, for the type of staffing that you employed based upon the intensity, and now you're also getting it in a higher wage index. So CMS came along and decided to do what is called the occupational mix adjustment. And through this slide, perhaps you can see what we're looking at here. I've got 2 sample hospitals. I'm going to use sample A and sample B. We do a survey of your wage information, but we're really only focusing on RNs, okay? This particular hospital, sample hospital A, 64% of their nursing staff is RNs, compared to a national percentage of closer to 71%. Okay, with me so far? Hospital B, 94% of their nursing staff is RNs, again, compared to that same national figure. Now, so we got hospital B with a higher number of RNs as a percentage of total nursing. So what we're going to wind up doing is looking at hospital A and hospital B, and we are going to increase the wage index for hospital A, which had the lower, and decrease the wage index for hospital B, which had a higher percentage. Unfortunately, this was something that was really pushed by a lot of rural hospitals who did not have the same mix and also did not have the same acuity level, but has turned out to be the impact once this was implemented is in many rural areas, they are actually being penalized because Joint Commission and other requirements that require certain levels of nursing staff for certain services means that they wind up actually having a higher percentage of RNs as to the total compared to hospitals that make a great deal of use of LPNs, techs, and like that. So even though it wound up actually having a negative impact on a number of rural hospitals because they are required to have a certain staffing level, and they wound up not actually being negatively impacted. But let's look at the impact of the wage index on a hospital reimbursement as we go through this program. This is in terms of the inpatient side. You can see that we start both hospitals with the same federal rate, but hospital A has a wage index of 1.0469. Therefore, it is greater than 1, and the labor share for hospitals with a wage index greater than 1 is 68.3. Hospital B has a wage index of 0.8698. The labor share as declared by Congress is 62% there. When I go through my calculations, I'm going to add back in non-labor, and you can see before I have even seen a patient, I know that for hospitals in location A, they're going to get paid almost $6,000 as a base rate compared to hospitals in location B with a reimbursement less than $5,350 as their base rate. The only difference here is the wage index, and as a result of the wage index, the labor share that is established. So getting your wage index right is vital, because this information is going to really drive all of your payment. And I will say that it's going to drive payment for various provider types, because there is not a wage index calculation for skilled nursing or home care. They're actually using hospital information within that area. Within the Medicare program, as I mentioned, we have a classification of patients, Medicare severity, MSDRGs, and that is the way we are determining how acute or how resource intensive the services are. The idea behind MSDRGs is that the more complicated case is going to have a higher level of reimbursement. There are, and I showed this to you earlier on the slide related to the pneumonia, but I am going to I'm going to have a base DRG, which is the, in the example I gave, the simple pneumonia and pleurisy, and I'm going to split them by whether or not they have complications and comorbidities or major complications and comorbidities. So where we used to have pairs, because we used to just say complication and comorbidity, we didn't have major complications and comorbidities. We used to wind up having pairs of DRGs. Now we have what we call triplets, because for a large number of the DRGs, we actually do have, for each condition, 3 different DRGs that we would be looking at. This gives you that breakdown again, similar to the slide that we saw earlier, that you come in with your basic diagnosis of simple pneumonia and pleurisy. You use the decision tree to make a determination as to which DRG or MSDRG the case routes to. This again takes the payment rate that we had for location A and B. We apply it to a, well, in this case, MSDRG 509 and arthroscopy. And you can see that no matter the location, the weight for that DRG 509 is the same in both settings. But again, you see that in location A, we're getting almost $1,000 more reimbursement for the service than we do in location B. Again, the only driver being the wage index. There are some other programs that or add-on payments that we look at when we talk about inpatient hospital services. We do have an add-on payment related to indirect medical education, and this is adjusting your base payment amount based upon the fact that you have a teaching program and that you have interns and residents, and interns and residents are learning. They might be ordering more lab tests, they might be ordering more x-rays, things like that, than a physician who has been practicing for a number of years. And therefore, there is a add-on to your payment for these added costs of operating a teaching program. Again, not the direct costs of the program, but those costs associated with the services that might be ordered by someone who is learning. Interesting provision here, and I hope my concern doesn't come to fruition, but the payment under the inpatient operating program for indirect medical education looks at your ratio of interns and residents to hospital beds. Interns and residents to bed ratio, IR. All of the other programs that CMS has put in place that reimburse for indirect medical education uses the ratio of interns and residents to average daily census. There is beginning to be more discussion, particularly at the Medicare Payment Advisory Commission, about payment for indirect medical education. They had discussion of that at their meeting last week before last. I think it was the 1st and 2nd. They had discussion of revisions to IME. The other programs, as I said, use interns and residents to average daily census versus hospital beds, because you know that you have hospital beds that really are not available. We went through that major discussion with under the pandemic, and whether or not beds that can we put beds in other places and things like this. So I think it is a concern if they are starting to look at this. If they use average daily census, it will likely reduce the indirect medical education payments going to hospitals. There are some other components of the that are added on to the inpatient program. One is an add-on payment related to disproportionate share. This was modified significantly under the Affordable Care Act, and the concept behind this is if you have a large volume of low-income patients, and I mean low-income patients across the board, not just Medicare low-income patients, then this is an opportunity under the Medicare program to offset your losses from uncompensated care. We look at your percentage of Medicaid and Medicare SSI patients to calculate a DSH percentage. You're going to have at least a 15%. Okay, don't know why it's doing this. Well, you're going to have at least a 15% DSH percentage in order to qualify. And then there's also some adjustments based upon the number of beds that you have. If you are either a rural hospital with less than 500 beds, an urban hospital with less than 100. There has been ongoing argument back and forth and a lot of litigation as to whether or not Medicare Advantage patients should be included in this DSH calculation. We continue to hear court case after court case, but I think we're about to have this settled. Under the ACA, previously you had an adjuster based upon your DSH percentage. What Medicare is now doing because of the ACA is they are blending this. They're using a portion of the reimbursement is tied to the original methodology that was looking at the total number of uncompensated care patients that you treated. Now they are actually making an adjuster also based upon the actual volume of uninsured individuals across the country. Has there been a decrease in the non-elderly uninsured? And they use that to reduce the pool of dollars that are available. For 2021, they proposed a significant reduction in excess of $500 million to the disproportionate share pool based upon the increase in individuals who had insurance. A lot of your comment letters for the proposed rule this year said, don't do it because look at what COVID has done. We suddenly have all these people who are uninsured. CMS wound up implementing a program where they are only reducing the pool by about $60 million. But you're going to wind up getting paid for disproportionate share based upon your share of the national uncompensated care for all Medicare DSH hospitals. So, and then finally, there is a provision under the inpatient program to pay for extremely high cost cases, and then also an add-on payment, and then also to reduce payment for short stay patients. Those who are transferred to post-acute care or to another acute care hospital, you will wind up getting a reduced payment if the patient has not stayed the average length of stay for that particular DRG. Something that I want to mention here, particularly for those of you who are perhaps in a hospital setting that is, you receive patients from a rural area and there is perhaps a critical access hospital with swing beds 35 miles away that is actually closer to where the patient lives, but that critical access hospital could not treat the patient or provide the level of care that was needed. Recognize that if you transfer that patient to skilled nursing after the completion of the hospital stay, transferring to skilled nursing, you do get a reduction in your DRG if they did not stay the entire or up to the average length of stay. If you transfer to a swing bed in a rural area, there is no reduction. So it might be something that you want to consider going forward, that if you have that opportunity to place a patient closer to home in a swing bed, as opposed to placing them closer to home or even closer to you in a SNF, you might actually be able to maintain a higher level of reimbursement if you transfer to swing. About a year ago, CMS recognized that that same provision applied to hospice, and they suddenly put in a change in policy so that a transfer to hospice would result in reduced payment, but they have not done that for swing beds as of yet. So if you are in a setting where there is a facility with swing beds and you transfer there, you do not get a reduced payment. Just something to think about going forward. I mentioned earlier that under the Medicare program, we started out with inpatient operating only. We then added inpatient capital in 2002. This came about, we actually had a payment for capital tied to cost from 1992, beginning in 1992, where we were transitioning. We had a 10-year transition from a cost-based payment system to prospective payment. But in 2002, everybody was on a prospective payment system unless you were a new hospital, because new hospitals receive 85% of cost for 2 years. This isn't a new facility to replace an old one. This is truly a new hospital. We have a federal rate, which is your base rate for capital, that is $462.33 per discharge for this fiscal year, or for the fiscal year 2020. Rather than using a wage index, and I love this about CMS, rather than using a wage index for adjusting the payment for capital, they adjust it by a geographic adjustment factor, the GAF. The GAF is your wage index to the 0.6848 power. So yeah, the wage index comes into play here as well. So it is a little calculation, but I think it's interesting that they say, oh no, we don't use the wage index, we use the GAF. Well, the GAF is tied to your wage index. We use the same DRGs as we use for inpatient operating. And what we're going to do is multiply your wage index adjusted capital rate times the rate for that DRG. We do have an add-on for inpatient capital under this program. However, that is tied to the ratio of interns and residents to average daily census as opposed to beds. So the add-on is lower under the capital PPS than it is under the inpatient operating PPS. Now, this is where we start going faster. We're going to look at the other payment systems very quickly. Let's look at inpatient, hospital outpatient. Again, the same concept of a prospective payment system. Prior to August of 2000, we were cost-based, and now we have a base rate that's called the conversion factor. For a calendar year 2020, this program is on a calendar year basis. The inpatient program is on a federal fiscal year basis. But under the program, your conversion factor this year is $80.79. It is proposed to go up slightly next year. Included in this conversion factor is capital. The inpatient program is the only program where capital is separate. I'm going to use your inpatient wage index, but I'm only going to apply it to 60% of my base rate, my conversion factor. I'm not where I had the 62% and 68.3 for inpatient. Everybody is at 60% for the outpatient program. Patients are going to group into ambulatory payment classification groups, APCs. There are 766 APCs for this current year. All I can say is, I don't know whether to say that a fee schedule is really a prospective payment system, or a prospective payment system is really a fee schedule. But this just gives you an idea, this and the next slide, because it's going to give you for APC 5311 with a weight of 9.4548, all of the various HCPCS codes that falls into that particular service. On the physician fee schedule, they're going to publish all of these CPT codes for the payment rate. For the hospital side, we roll it up into an APC and we publish it with a weight and a rate. So they are very, very much the same type of payment methodology. Gives you just another service, again, within the same GI, but more intensive services, and you can see a significantly higher rate tied to these particular conditions or procedures. Under the hospital prospective payment system for outpatient services, there is no add-on payment for medical education. There is no add-on payment for disproportionate share of a low volume patient. So those are out, nothing additional. You do have increased payments for cost outliers, extremely high cost cases. And under the Medicare program, you do have special payment rules related to new technologies coming on the market, and also for new drugs and medical devices, where there is going to be more of a pass-through payment methodology for 2 to 3 years as the drug or medical device comes on the market. So a new way of delivering care versus a new drug or medical device, those are going to get you additional payment, but for a limited period of time. I mentioned way back that for most medical services paid under Medicare Part B, which these outpatient services are, for most of them there is a 20% patient liability for outpatient services. Well, that's not the way it works necessarily for beneficiaries who are receiving services in a hospital outpatient setting. And let me give you a little bit of background. Prior to the transition to outpatient PPS in 2000, Medicare beneficiaries paid 20% of your charge. So what the patient paid had nothing to do with what CMS allowed on a particular service. It was strictly tied to what your charge was. So let's use as an example, a patient came in for a particular service and your charge was $500. Very simple example. Your charge was $500. Medicare allowed $100 for that service. Well, you reduce from what Medicare allows the beneficiary copayment, and 20% of $500 is $100. Therefore, the beneficiary just paid the entire bill. There was no payment due from the Medicare program because the beneficiary's copayment was 20% of your charge. When CMS implemented the outpatient prospective payment system, there was a lot of back and forth at what do we do with beneficiary copay. Because for all other outpatient services, physician services and the like, the beneficiary pays 20% of the allowable. Well, if CMS had set beneficiary copay at 20% of the allowable back in August of 2000 for each of the APCs, there would have been we wouldn't be talking 2026 or even 2023 as an expiration date for the trust fund. Actually, that's not true because this is paid through Part B. It would have been significant increase in the expenditures for the Part B program, because prior to the implementation of the outpatient prospective payment system, beneficiaries were paying on average in excess of 50% of the total allowable amount. There were some very high-cost services or highly reimbursed services that the beneficiary's liability would have been closer to the 20% of the allowable. But for most services, the beneficiary's liability was close to 50% or more of what was actually paid under the Medicare program. So in order to implement the outpatient prospective payment system, CMS had to come up with a new way to do this. First thing they did is they said, for any new services, any new APCs that come online, we will set patient liability at 20% of our payment. So that covers anything that's new. For anything that was in place in 2000, they began a transition of lowering, actually I can't say lowering the Medicare patient liability. They basically are keeping it at what was calculated patient liability was back in 2000. What was the average liability for a patient for an MRI? And they froze it at that spot, recognizing that over time payments would go up. And so eventually beneficiary copayment will be 20% of the APC payment as rates go up over the years. Now this program came in 2000. There are some services that are now at the 20% mark. But the calculation that was done back in 2000 was that it would take 62 years for the copayment for an MRI to be equal to 20% of the payment for an MRI. So again, beneficiaries are still paying more of the total bill than they do for services provided in a non-hospital setting that are not services that are not paid under the outpatient prospective payment system. Just one of those little things letting you know. This gives you the calculation for the outpatient. This is based upon the fiscal year 2020 final rule. We're looking at the APC 5312 with a payment rate, with a weight of 12.4295. You can see that for both locations, the labor share is the same. They are both at 60%. For inpatient, we had two different labor shares, but the same labor share for both. Again, my wage index is the only thing that varies. Hospital A winds up with a reimbursement of a little over $1,000, whereas Hospital B, for the same service, their reimbursement is just a little bit over $900. Again, the only driver in this situation is going to be the area wage index. So again, I've got to stress the importance of that and the work that your reimbursement team does on getting that right. Now we're going to flip very quickly through the other prospective payment systems. Let's look at inpatient rehab. This, it doesn't matter whether you have a distinct part unit within your acute care hospital or if you're a freestanding rehab facility. Your conversion factor for rehab is $16,489 per discharge. There is not a rural adjustment for rehab. There had been for a number of years. Capital is included in that $16,000 reimbursement. We're going to use your hospital wage index, the wage index within that market. However, we do not look at any geographic reclassifications. We do not look at the rural floor. Those are excluded from, and so let's use that example of the panhandle of Florida that from an inpatient side and from an outpatient side, your wage index, which is lower than the statewide rural, is brought up to the statewide rural. Well, for rehab services, you don't have that benefit. You get your true wage index. And those hospitals I mentioned in Miami that previously had reclassified to Broward, they go back to their own wage index for rehab services. It is considered that 72.7% of the 16,489 is tied to labor, and therefore that is going to be adjusted by your wage index. Patients in rehab are going to group into a case mix group. I think it's kind of interesting. We had DRGs, we had APCs, and now all of a sudden we get case mix groups. It's kind of a nondescript term, but I just thought I'd mention that. Patients, you do an initial assessment of a patient as they present to rehab, and the patient is going to group into one of 21 rehab impairment categories, or RICs, and then we're going to further stratify those patients based upon their motor and cognitive scores, their age, comorbidities. So under rehab, although patients initially group into one of 21 RICs, we wind up with 348 case mix groups for actual reimbursement purposes. There are no payments for medical education under rehab. We do have reimbursement for cost outliers, extremely high cost cases. We have something similar to disproportionate share. However, unfortunately for Florida, it is called the lip adjustment, but it's a lip adjustment for rehab. It is not the Medicaid lip program that we're familiar with, but the low income percentage adjustment under rehab is equivalent to the disproportionate share adjustment for inpatient acute. But in this particular case, we are looking at the share of Medicaid and Medicare SSI patients treated within the rehab unit or hospital, not if you are a unit across the entire hospital, but just within your unit. If a patient is transferred to another rehab facility, a long-term care hospital, back to an inpatient hospital or nursing home, and the length of stay within rehab was less than the average length of stay for the case mix group, then there's going to be a partial payment, very similar to what you have for acute care. And the rehab program has something that is called an interrupted stay. And in the case of rehab, if a patient is discharged and returns within 3 days, it's treated as a single admission. You're not going to be billing that as 2 encounters. You're going to be billing it as a single encounter within the rehab program. Let's look at psych. And under the psych program, now, this is prospective payment system, but we use a per diem. And the per diem rate for psych for this year is $798.55. This is, again, just like rehab, it is an inpatient acute. It is paid on the federal fiscal year basis. I mentioned outpatient, and also I'll mention physician. They are paid on the calendar year basis. But inpatient psych hospitals, $798 a day for treatment of a patient. However, if you are, let's say, a critical access hospital or another rural provider who has psych beds, you're going to get an add-on of 17% to your payment for treating patients within a psychiatric unit or hospital. And this goes for those critical access hospitals that dedicate some additional beds. I think they can have up to 10 additional beds for psychiatric patients. They're going to get paid under Psych PPS, but they're also going to get a 17% add-on. Excuse me. 75% of your per diem rate is considered related to labor, and you're going to use, excuse me, the hospital's wage index without reclass or roll floor. So again, that example that I gave from Miami or the Panhandle, you're going to get your true wage index. There are 17 DRGs that are applicable to inpatient psychiatric PPS. If you wind up treating a patient who doesn't fall into one of those 17 DRGs, then you would be paid under the inpatient prospective payment system as opposed to the inpatient psych prospective payment system. There are all kinds of adjusters for the psychiatric program. First of all, you're going to have a teaching adjustment here, and it's going to be based upon the ratio of interns and residents to average daily census in the psych hospital unit. Going to get an add-on payment for high-cost cases. There is no disproportionate share adjustment. This has been an issue of major argument for a long time because if you look at the patients who wind up in your inpatient psych unit, particularly this Medicare population or the overall population, you do tend to have a large number of patients who are eligible for Medicaid or Medicare SSI, but they are not looking at that to make any type of adjustment, which my gut feel is that's wrong. And then we have certain patient level adjustments, and it's amazing to look at all of these adjusters. First of all, there's an adjuster based upon length of stay. I gave you the per diem. There's going to be an adjuster to that per diem per day, so that we're going to start reducing your per diem based upon length of stay. However, if you are a hospital with an emergency department, whether that patient who is admitted to the inpatient psych comes through the ED or not, if you have a dedicated ED, you are going to get a higher rate for day one than hospitals that don't have a dedicated ED. As an example, if you're an acute care hospital with an ED, you get 131% of that per diem. Whereas if you are a freestanding psych hospital that doesn't have an emergency department, you're going to get 100% of that first day per diem. So greater reimbursement if you've got a dedicated ED. There is also going to be an adjustment for age for all of the patients who are admitted to a psych unit. If you are over 65, you get higher level of reimbursement. If you are under 65, it's lower. And again, think about those patients who are eligible for Medicare based upon disability. Many of them are because of a mental deficiency. There's going to be age adjustment there. And if the patient has various comorbidities, there would also be adjusters to the DRGs based upon additional conditions that the patient might have been diagnosed with. Home health PPS, we've only got a couple to go. As of the past year, we have moved to a 30-day episode of care with a payment rate of a little over $1,800 per episode. That's your 30-day episode. That does include capital. It also includes non-routine medical supplies. Previously, when we had a 60-day episode payment, that was closer to about $3,600, $3,700. For that 60-day episode, hospital and home health agencies were paid separately for non-routine medical supplies, but now they are incorporated into that 30-day episode rate. They use the hospital wage index without reclass or rural floor, and it applies to 76.1% of the episode rate. And one thing that's important to remember is under the case of home health, they use the wage index that is based upon the location of the patient, not where the home health agency is located. So that is an adjuster that they make there. No additional payment for indirect medical education or disproportionate share. There is an add-on for patients in rural areas. Patients group into home health resource groups using both the principal diagnosis to group the patient. It used to be grouped based upon therapy, but now it is based upon the principal diagnosis. And the patient is then assigned to one of 432 case mix groups based upon admission source. Did they come in from the community or were they admitted through a hospital setting? The timing of the 30-day period, is this the initial 30-day period or subsequent 30-day period? The clinical grouping, of course, of the patient, their principal diagnosis, their level of functional impairment, and then any comorbidities. All of those are looked at to make a determination for health patients and their reimbursement. Lastly, for skilled nursing facilities, Patients are classified into a clinical category based upon their primary diagnosis, and this gives you an idea of the clinical categories that we are looking at for skilled nursing. We are dealing with a new skilled nursing prospective payment system, the PDPM. And so then I gotten my patients grouped into my clinical category. I am now going to look at various components to further stratify those patients. I'm going to look at their functional score from a physical therapy and an occupational therapy perspective. From a speech language pathology perspective, I'm going to look at whether or not there is an acute neurologic condition, any type of cognitive impairment, swallowing disorder, anything like that. I'm going to look at the level of care provided and the clinical conditions to get my appropriate classification for nursing services. And then I'm going to look at a comorbidity score for non-therapy ancillaries. I take all of these and then I have a per diem, and that per diem rate is going to vary just like it did with psych over the course of the stay. So my per diem is adjusted as well as my patient, I guess I would have to say acuity, because as they improve, your functional scores are modified and things like that. I do have both urban and rural per diem rates under skilled nursing. Those rates include capital. I'm using the hospital wage index, but not looking at geographic reclassifications or rural floors. And I apply this to 70.9% of the per diem rate is adjusted by wage. And the one thing I wanted to mention here as a special aside under skilled nursing is there is a provision under skilled nursing PPS that addresses consolidated billing. If a patient who is in a SNF receives a service that the SNF should have provided, then Medicare will not pay that other provider for that service. It has to be bundled into the SNF service, and then the SNF would pay the provider that provided that care, not Medicare. They would not pay the other provider directly. Now, I'm sharing this with you, although I know it's hard to see from a slide perspective, but this is a comparison of the Medicare prospective payment systems that just really goes through all of the various programs and tells you what is the definition, how do they define, or what do they call the federal rate, what is their rate year, what is their percentage of adjustment for labor, and do they have a rural add-on, things like that. This particular grid, you have it in a slide. It is updated by the FHA every year. It is a part of the FHA's Medicare 101 manual. That Medicare 101 manual was offered to you, I believe, as you registered for the program. But I have several slides here that just give you an idea. Basically, Medicare 101 goes through every payment system, including Medicare Advantage, physician, all the rural types of providers, some things that we obviously didn't talk about today. Each of the sections includes a really good discussion of the various payment methodologies, but also gives you calculations, those provisions from the Affordable Care Act that were specific to that particular payment methodology. It gives you information on beneficiary liability and the like. This just gives you an idea of a sample page out of the program, the reference section where we give you all of the final DRGs. Again, calculations of your payment methodologies. And the one thing that I really wanted to tell you about this is for years this has been a not hardback, but a 3-ring binder. As a matter of fact, it's right there on my desk, a 3-inch 3-ring binder. But FHA staff worked very hard this summer to move this into an online manual. And it is password protected. It is a subscription for you But we do think that this was the way to go in terms of moving this into an electronic environment. You can contact Rebecca Ryan at RebeccaR@FHA.org, and Becky can provide information to you on subscription to the manual. I do know that some of you subscribe to the manual for your organization when you first registered for this. I do know many years ago hospitals received hardback manuals, but who knows if they've been kept up. So I just wanted you to know that those were out there. I'm providing this slide with my email if you have questions about this, but also Amy and Diane, if there are questions from the line, I'm glad to take any.
Thank you, Kathy. That was very, very informative and definitely information-packed, so we appreciate that. For our participants, if you have any questions, you may type them into the questions area, or please, if you'll hit *6, that will unmute your phone line if you're participating by telephone. So *6 to unmute your line.
And Diane, just as a reminder, the next program will be on quality and quality payments under Medicare.
Yes, and that's next Wednesday, October 21st.
Yes.
I don't see any questions that have come into the queue.
Well, folks have my email address if they need to reach me as well, and I'm always willing to help in any way.
Yes, please reach out to Kathy, or you.
Particularly for members of the FHA.
Yes, thank you. And if you also, you can email education@fha.org, and we can get information related to Kathy, or if you have questions for us. There being no, I don't see any questions at this time, but Kathy, I do want to thank you so much, and we're looking forward to next week's webinar as well. A reminder for everybody, following today's webinar, you will receive an evaluation form. Please know your feedback is important to us, and we do look at those, so please take a moment and respond. And if you have any questions, again, please contact us, education@fha.org. And this ends today's webinar. Thank you.
Thank you.